first, I mean, you've had dental oral health on the radar screen for 10 years, I'm sure, with the overall center. When are you focusing more on it?
So it's really been an interesting kind of progression. So we'd been doing work in oral health for a number of years, and one of the things that we got our start on was, and I'm away the talk, but HRSA funded us to do an assessment of dental hygiene scope of practice across states. From there, we wound up doing some work with the ADHA. We wrote a white paper for the IOM. We did a study of PA curricula and the extent to which they're embedding both didactic and clinical experiences in conducting oral health assessments. We've worked with Hugh Foundation to do state-level assessment. And then probably the biggest thing that happened was the being awarded a cooperative agreement with HRSA to do a oral health workforce research center. So it's been an interesting progression, but we've had our hand in it for a while.
Well, yeah, I'm sure. That was always part of the work, the center activity, as I recall, was pretty comprehensive anyway, so this is good, yeah.
Yeah, no, it's been real exciting. We're just thrilled to have the cooperative agreement that really allows us to do more and to help people better understand what these issues are.
Yeah, and I'm glad I was connected with Noah to get started on partnering with them on stuff, because there's enormous potential with that group.
Absolutely.
It's been a long time.
Merle, do you know Renee Josko?
I know him, but not personally.
So she's a dentist. She's at HRSA. She, for a while, was our project officer, and she was actually the one who helped us make the connection to NOAA and had suggested that she thought they would be a great resource. So it's really good to.
Is she in profession? Is she in the health professions, or is she in workforce, or is she over in primary care?
She's moving around. So she was in medicine and dentistry, then she moved to the National Center for Workforce Analysis, and now she's, I believe, in the policy shop. So she's been around, done a lot of things, and knows everyone. So she's just been a great resource for us.
A guy named Jay Anderson was the lead dental person there for a couple of decades, actually.
Right. That name's familiar.
Yeah, he was in the primary care side, but he was the only, senior dental person in anywhere in HRSA for years.
Yep.
He retired a few years ago, of course. All the old folks that I know retired.
Hey, few of us are still hanging on, right?
Well, yeah, but you're much younger than I am.
Yeah, I started working in this area when I was, 15? And
something like
so
that.
I'm very young.
So you're only 20 years into the field.
Exactly. Lots of time left.
So we'll get started. The webinar is running, and we just edit that out whenever we want to. So
okay.
So thank you very much, all of you, for joining us for the current session of our ongoing seminar series in health workforce research. This is part of the GW Health Workforce Institute, as everyone knows. And the material that you've received in the mail and the email has the URL so that you can check out the other activities of the Institute here at GW and follow the full range of activities that we're doing. My name is Merle Cunningham. I'm co-chair of the speaker series with Polly Pittman, and I'm delighted to welcome everyone here, both in the room and online, to this series. We're very fortunate to have our session this particular month with oral health, and we're privileged to have with us Jean Moore from SUNY Albany and her folks. Jean has been involved in this field for over a decade. She's the director of the Center for Health Workforce Studies in Albany has been actively involved in oral health stuff, and more recently received a cooperative agreement from the Bureau of Health Workforce to focus on oral health issues. With that, I'm going to go over to Jean. They'll be doing the presentation with her team members, and following the presentation, we'll be opening up for questions from the larger group. So take it away, Jean. Thank you.
Thanks. Thanks, Merle. So this presentation, Workforce Innovations in Oral Health, I'll be presenting some, and my co-presenters are Margaret Angelier and Bridget Baker. Both are researchers here at the center, and they predominantly work in the field of oral health research. So I want to just tell a little bit about the center. So the Center for Health Workforce Studies at UAlbany was established in 1996, and it was actually established by Ed Salzberg, who is now at GW. And we do exactly what our name implies. We study the health workforce with a goal to inform public policies, the health and education sectors, the public, and we draw our funding from a broad array of groups interested in health workforce research. So presentation, we want to talk a little bit about our oral health workforce research experience, and then talk about why this matters. Why, we want to make the case for why oral health workforce research is important. And then we'd like to review some of the key themes that we've found from the work we've done to date. And then finally, to consider the stakeholders who use what we do to inform workforce strategies that can increase access to oral health services. So I'm going to start with some of our older work, but I think real relevant work. So in 2001, we actually received funding from HRSA to do something that assessed scope of practice dental hygienists. And essentially what we did was we developed a scale, which you're going to be hearing about in a little more depth later, and applied and reviewed all of the scope of practice laws, regulations for dental hygienists, and applied this scale and actually ranked and compared different states in relation to scope of practice. We also work with the American Dental Hygiene Association in helping them develop a dental hygiene master file. We produced a white paper for the IOM on the oral health workforce in the U.S. And then a more recent work was through NCCPA, which is the National Certifying Body for Physician Assistants. We surveyed PA education program directors to understand the extent to which they were embedding oral health curriculum, oral health assessment, screening into the curriculum of their programs. And again, we're going to say a little bit more about that. We've been involved in state studies of oral health, and the list is the states we've done and in fact are doing. Kentucky is still wrapping up. Most of this work has been funded by the Pew Foundation because oral health access has been an extremely critical issue for them, and to be honest, trying to understand oral health access issues, it really does require state-level assessments of looking at who are the subpopulations with limited access, what do we know about the workforce, and what are some of the strategies we can use to try to bridge gaps. Most recently, in 2014, we were awarded a cooperative agreement from HRSA to establish an oral health workforce research center. So me, Margie, Bridget are part of the research group, as well as Beth Hertz from UCSF, who also is a researcher of the center. So the list of projects that we've completed for the first year are listed, and we're going to be talking about some of them during our presentation. And one of the things that we've included in the PowerPoint are a series of reference slides that can point you to some of the reports that have been released as a result of this research. I will tell you that we're still wrapping up some of the studies, so that not all of the studies have been posted, but they probably will be in the next 8 weeks. So we've given you a link to the Oral Health Workforce Research Center website, and that's where you'll find any of the reports that aren't listed on the resource slide, but should be appearing on that website relatively soon. Now I'm going to turn over to Margie Langelier, and she's going to talk about why we need oral health workforce research, why it matters.
Good afternoon. It's my job today to just tell you a little bit about why oral health is important, what kinds of disparities exist, and why integration of oral health services with primary care services is an important strategy to address those disparities, and then to give you some idea of the organizations and the providers that are in fact adopting programs and changing care delivery systems so that oral health services are more directly integrated with primary care. So the first I'd like to tell you is that we really need to focus on the fact that caries is a chronic disease, and it is transmissible. I think many fail to recognize that. Caries is linked to so many other systemic diseases. For instance, oral bacteria causes acute endocarditis. It is suspect in infections in joint replacements and other implants in the body. Diseases manifest themselves first in the mouth, and so looking at the oral cavity can be an indicator of the presence of diabetes, of kidney disease, of HIV, of eating disorders, of herpes and HPV. It's also linked, oral bacteria is also linked to preterm birth and infant mortality. It is, there's also symptoms in the mouth from use of all kinds of medications that cause dry mouth. Many of the medications that are used to treat things like high blood pressure or to mediate substance abuse cause dry mouth and therefore have symptoms in the mouth. And it's also a place where dentists, as first-line providers, can see the evidence, things like substance abuse that require further referrals. So recognizing that oral health is extremely important and oral disease is also part of systemic disease is a first step in understanding why integration of oral health and primary healthcare services is important. What do we find? We find, in fact, that oral health and primary care are not integrated generally within the healthcare system. Dental is delivered in a completely different delivery system than medical services, whereas in healthcare, physicians are now moving to large group practices, often managed by hospitals or provider management organizations. Dentistry still works in a small business paradigm where dentists work in solo practices or with another dentist. There are different systems. Many of you know that dental insurance, along with eye care and in the past mental health insurance, were always cut out. Public insurance programs have been very helpful in recent years with trying to integrate dental insurance with medical insurance through contracts with MCOs. However, even Medicaid MCOs, they have very little experience with providing dental care, so healthcare insurance carriers are still contracting with dental MCOs to essentially cover out those services. So even when there's an apparent integration of insurance coverage, there's still some bifurcation in the system, and it's still essentially a carve-out. So there's little transparency between systems. Dentists who tell us that when they see a publicly insured patient on Medicaid that they're having to, for instance, bill their health insurance company for the anesthesia provided during a dental treatment services, and then they bill the dental insurance carrier for the actual dental treatment services. So those are just some indications of the lack of integration. One of the biggest things that we're hearing in the age of meaningful use is that electronic medical records and electronic dental records do not interface. Even in healthcare systems like FQHCs, where both of those services are provided, you know, the interfaces are expensive, and so the system is lagging in creating seamless access for medical and dental providers to those records. As a result, referral networks between physicians and dentists are very, very limited. Community physicians who, you know, may even practice next door to a dentist may not even have a referral network with those dentists. So these are all things that are, you know, practical indicators of lack of integration. So as a result, we have a lot of oral health disparities. As would be predicted, many of the populations that suffer from oral health disparities are the poor, minority populations, including immigrants and refugees, American Indians, children, and particularly children from lower socioeconomic groups, people with special needs, and the elderly. One of the barriers and one of the factors that impacts oral health disparities is a low level of oral health literacy, particularly among groups. There is a lack of value for oral health generally, and also a lack of understanding of the need for routine services or of their importance. The other issue that affects oral health literacy are intergenerational myths and cultural fatalism in certain groups of being destined to lose all their teeth and, as a result, not caring for primary teeth or for adult teeth. There are geographic disparities in rural areas and in inner city urban areas that certainly impact the oral health status of the population. Oral health really is a public health crisis. We're beginning to recognize that people who have oral health problems or disease are missing school. There's lost productivity at work. There's inattention in the classroom from children who are suffering from dental pain. And public systems, particularly Medicaid programs and hospital systems, are beginning to understand that some of the uneven access to oral health care is creating extreme stress on emergency departments where patients are showing up with ambulatory care sensitive dental problems that could be treated in the community and instead are being treated at a very high cost in emergency departments. It's important to remember that this is a preventable disease. It's 5 times more prevalent in children than asthma, and So it really is a public health crisis. So what are access barriers? I've already mentioned oral health literacy. Another is oral health provider availability. And by availability, we mean several things. Some will cite a shortage of providers, particularly dentists. Others will suggest that there isn't a shortage of dentists. There's simply a maldistribution of the workforce based on provider preference for places of practice. Dentists do tend to practice more often in metropolitan areas simply because those areas have enough of a service base that it will support a practice. And many dentists, especially new dentists, are driven by high educational debt to be sure that their practice is sustainable and also profitable. The other thing that affects access is whether or not the existing dentists, the dentists in the community are willing to treat patients with Medicaid. We find in our examination of state Medicaid programs that there is a core group of dentists who will treat any Medicaid patient, but those numbers are small. There are, in some states, a fair number of dentists who will treat Medicaid patients, but many limit the number of Medicaid patients on their caseloads. And then the other thing that impacts provider availability is scope of practice limitations, particularly for dental hygienists who still in some states must practice under the direct supervision of a dentist in a dental practice. Resources paid for care are also limited. Public insurance really does drive access to care, particularly for underserved populations. And many of the Medicaid programs do not provide an adult dental benefit, or they provide only an emergency dental benefit for adults. Even those with dental insurance may have high copays or annual limits on the amount of dental services that will be paid by the dental insurance in a year. So all of the financial barriers limit access to oral health services. So what are the themes that are emerging from our research, which is mainly workforce focused, but it's very difficult to focus on oral health workforce without also obtaining an understanding of the other things that impact whether or not people access care. So themes that are emerging are, as I said before, integration of oral health in primary care is a key goal at every level, at the government level, at the provider level, and also at the program and patient advocate level. And then the workforce stations that are occurring tend to take different avenues. One of the first is training primary care workforce to provide oral health assessment and screening services. Another initiative is expanding the scope of practice for already existing oral health professionals, including dental hygienists and dental assistants. And then the third track is that several states are now creating new oral health workforce models in order to address gaps in care. One of the other things that we're finding in our research is that in dentistry as in healthcare, many providers, especially federally qualified health clinics, are developing team-based approaches to care. And then the thing that we're seeing in our research are some very interesting local solutions to oral health care needs in communities. We've come to believe that local solutions are very, very important. There are, system-level changes that are needed to support local solutions, but some of the most effective programs that have been created through community collaboration in areas where oral health services are not readily available. So the study that I'm going to talk about was one that Jean referred to before, and that was we recently conducted case studies of FQHCs in 9 states to understand their strategies for integrating oral health in primary care. FQHCs are uniquely positioned to provide integrated patient-centered health and oral health services. They are mandated under their grants from the federal government to provide or to refer for oral health services for children consistent with their EPSDT benefit and for preventive services for adults, either through direct provision or referral. I would say that approximately 80 to 85% of FQHCs across the United States are currently directly providing oral health services. In some FQHCs, in fact, there are more oral health services being provided than primary care health services because of the need within particular communities. So FQHCs, because they co-locate or locate nearby, both primary and oral health, have sort of very unusual opportunities to innovate and to collaborate across clinical disciplines. The other thing that's happened that sort of encouraged FQHCs to adopt innovative strategies is that when state governments are adopting new workforce policies, oftentimes they will require that the workforce only practice in settings where a majority of the population is underserved for oral health services. So, for instance, dental therapy model in Minnesota and many of the public health dental hygiene models that are adopted by states require that a certain percentage of the population that is seen is either Medicaid eligible or uninsured, qualifying for sliding fee scale services. What did we find in FQHCs? We found that they're using all of the approaches that I suggested. They're training their primary docs to provide oral health assessments. They're using existing oral health professionals in different ways, and they are also engaging with new oral health workforce models. And they are also using all of those in a team-based approach to care. So, as would be expected, the traditional dental team in the FQHC is the dentist, the dental hygienist, the dental assistants, and where available, dental specialists. That team is extended with dental students and externs who are rotate through those clinics. Also, the team includes the primary care providers within the FQHC who, in the case of children, are often screening for oral health and then referring to the dental clinics. And then there are other oral health care team innovations that work with the core dental team. Many of these innovations practice outside of the FQHC setting. Public health dental hygienists, for instance, are used by FQHCs in a lot of school-based and school-linked oral health programs. Community dental health coordinators are community health workers who work in the community, doing case finding and outreach and education. Two models that are used in clinic are dental therapists and expand function dental assistants who are used both in private practice and in clinic. They allow the dentist to cut a tooth, and then the dental assistant can finish by placing and carving the amalgam. It increases the capacity within the clinic for the dentist to provide the services, treatment services. So they're extensively used within FQHCs. Let me talk a bit about the use of dental residents and student externs in FQHCs. 5% of dental services in the U.S. are provided in private dental practices. So it's very important that dental students be given some exposure to the needs in the underserved communities so that the recognition when they enter private practice of the need and within those communities. FQHCs are now hosting dental student externships and also residency programs, and Lutheran Family Services is a wonderful example of a program that has extended the education of dental students and residents. The program is managed over 200 dental residencies throughout the United States in community health centers where students learn, work with dentists, the underserved population. Lutheran Family Health Services itself has a main clinic that is staffed by over 70 dental residents, precepted by dental educators, and then they have 6 off-site clinics serving various communities in Brooklyn, New York, all of which are underserved. So one of the things they're hearing from FQHCs is that hosting student externs and residents is a very good tool for recruiting new dentists to the clinics. It's also a way of educating dentists who will enter private practice on need, so that many will consider accepting Medicaid patients in their private practice, and some will actually take a day a week and work in a local community health clinic because of their exposure to the needs of the underserved. So another project that we completed, which was taken because we're recognizing the need for training of primary care clinicians in oral health services. Several years ago, the Society of Teachers of Family Medicine created an oral health curriculum that's available online. It's called Smiles for Life. It teaches practical skills for examination and oral health assessment. And PA programs have been using this curriculum and other curriculums to train their students in oral health. So we did a survey of education programs and found that the majority of education programs now have integrated curriculum on oral health, and that almost all provide didactic instruction, and a majority also provide clinical training in oral health examination and disease identification. Several programs also engage with interprofessional education with medical students, nursing students, even pharmacy students in oral health. So this year we're going to be conducting a survey of PAs who've graduated in 2014 from one of the education programs that did provide oral health, to find out what the barriers to integration of oral health services in clinical practice might be.
Thanks, Margie. Now we're going to hear from Bridget, who is going to talk about expanded function dental hygienists and dental assistants.
Good afternoon. Like Jean said, I'm going to be going over some of the interesting things happening with expanded function dental hygienists and dental assistants. In 2000, we had a DHPPI, or our Dental Hygiene Professional Practice Index, which was a numerical scale that quantified the scope of practice or the legal environment for dental hygienists. It was state-specific. It was interesting because we used the scale to both evaluate and quantify a scope of practice. It is important to distinguish, however, between the index itself and the measurements for the state. With the 2001 scope, we had used a set of variables that were used to quantify, and these were reflective of types of settings, tasks, supervision, and the opportunity for Medicaid reimbursement for dental hygienists. The full report for this body of work is included in our references at the end of the presentation. High scores for the states indicated more autonomy for specific settings, tasks or functions, and the opportunity, of course, for reimbursement for dental hygiene services. And importantly, the Oral Health Workforce Research Center was funded to update the existing scope of practice for dental hygiene. Clinical practice has broadened in many states. There's been a lot of changes over the last 14 or 15 years. And one of the things that we found was that overall states that had originally received a higher score for scope of practice remained relatively high in the 2014 scores. Some states did lose ground, however, and this sometimes we found this was due to regulatory or statutory changes. And other states with originally lower scores in 2001 made some noticeable advancements in terms of scope of practice. One of the other things that we found in our research was that most states do recognize public health practice for dental hygienists in terms of permitting provision of preventative services, either under general supervision or unsupervised and without prior examination by a dentist. One of the things that comes up in our research in this area is why scope of practice matters. One of the things that we found in our research for dental hygienists is that dental hygienists are an important point of contact in providing evaluation and assessment of a patient's oral health status, oral health education, preventative care, and referral to dental providers for necessary treatment services. Our research also indicates that a broader range of services may indicate greater access to and utilization of oral health services. And of course, in our 14 studies, we also found that multi-level modeling indicated a very significant relationship between a broad scope of practice for dental hygienists and positive oral health outcomes. We also found that our existing scale may not actually accurately assess the current ideal practice for dental hygienists. As I discussed before, there's been some significant changes over the last 15 or 15 years, and some of the variables in the index that were originally developed in 2001 may not reflect what is, as accurately what is happening in the actual field for dental hygienists. We found that with some states, they had achieved near perfect scores in 2001 using our 2001 index. So we began this discussion of the need to update and account for things like expanded tasks and allowable restorative services. Some of our critical elements for a new scale may include, of course, the ability to supervise dental assistants, with some services requiring two-handed dentistry, the provision of basic restorative services that could benefit from dental oversight, supervision, and consultation, and the ability for dental hygienists to provide local anesthesia without direct supervision for certain periodontal procedures. Moving forward with our dental assisting workforce study findings. Dental assistants are an important part of our oral health team. And over the last decade, states have been expanding scopes of practice for dental assistants. So in this study, we reviewed the available data on dental assistants to try to get a better understanding of the workforce, and we examined state-specific scopes of practice for dental assistants. Our research indicated that there are multiple educational pathways into dental assisting, everything from on-the-job training to formal dental assisting education training programs. There is an incredible amount of variation in state requirements for dental assisting training, titles, and allowable tasks. And one of the things that we found was that over 40 identifiable titles based on qualifications, trainings, tasks that dental assistants are allowed to do in a workplace. Expanded function dental assistants. This is a very interesting part of our study. This is an emerging dental assistant classification. Expanded function dental assistants are defined as being legally permitted to perform more complex tasks. So some things that we pulled out were for, in terms of preventative services, being allowed to engage in coronal polishing, applying fluoride varnishes, and sealant applications for patients. Two of the notable restorative functions that we found in our study on FDAS was placing and finishing dental restorations and the creation of temporary crowns. In the scope of practice for states, there are signs of increasing state-level standardization, and this is really seen in terms of the requirements for education, training, certifications, and competency testing. Research also indicated that using FDAS in oral health teams may contribute to greater capacity and efficient residency for dental providers. Now I'm going to turn this back over to Margie, and she is going to talk about state and local strategies to expand access to oral health services.
So I'm going to tell you just a little bit about some of the things that we found in our state-level studies. One of the reasons we selected Maine is a state that is exemplary in the various strategies that it's chosen to address oral health access issues. It's a rural state with areas of where populations have lower socioeconomic levels, so they were really struggling to provide oral health services to the rural areas in Maine. Has legislated a very range of workforce especially for dental hygienists. So in Maine, dental hygienists can practice as an entry-level dental hygienist, can practice as a public health dental hygienist, an independent practice dental hygienist, and since 2014 as a dental hygiene therapist. There are a range of different programs that these particular dental hygiene certifications are enabled to work in. There are many initiatives using them. Maine has a number of public health dental hygienists working in school-based programs, in nursing homes, in community health centers, and even in halls and churches providing oral health services. Have a medical initiative using primary care providers called Into the Mouths of Babes. So pediatricians and workers in those primary care practices can screen and place fluoride and be reimbursed for those services. They also created, just opened a brand new dental school in 2013, which will graduate the first group of new dentists for Northern New England in 2017. 43% of the dentists accepted to that program each year are from Northern New England, where the supply of dentists is less than desirable. There's another state that we worked in that is confronting its oral health access issues on a number of fronts, and they have a very robust public health hygiene program with over 200 dental hygienists working in 50 public health programs. They're working in mobile dental vans, in migrant farm worker programs, treat tens of thousands of patients annually who would not necessarily access services in mainstream dental practices. Another thing that Michigan has done, which is exemplary, is that it has taken its Medicaid program for children and converted it to a program in cooperation with Delta Dental of Michigan called Healthy Kids Dental. Delta Dental engaged its existing provider network, so in 80 of the 83 counties, all children on Medicaid can access the Delta Dental provider network for services, and in the other 3 counties, beginning in last October, children up to age 12 can access that network. There's a particular initiative in Michigan that was very interesting. It was called the Calhoun County Dental Partnership. It is a pay it forward initiative that was conceived at the community level by social service provider organization that engaged the local hospital, dentists, and patients in a dental service network. Patients who want to receive services from the partnership must volunteer their time in the community and earn the dental services by completing a certain number of hours of volunteer work that's equated to the cost of the dental service. The dent agrees to provide the service free of charge. There is some grant money to support the cost of supplies, although many dentists in the community do not accept it, and that's been an extremely successful program. In Michigan as well, the public health departments have combined to create a not-for-profit organization called Michigan Community Dental Clinics that is an administrative body managing 26 dental clinics affiliated with that many departments of health across Michigan to serve the needs of the underserved. In California, they have created a virtual dental home. This was a demonstration project that used registered dental hygienists in advanced practice, working in the field, taking x-ray and using laptop computers and digital cameras to transmit their findings to local community dentists who then determine treatment plans, and also built a referral network for the children that were screened through these programs. This demonstration project resulted in very recent legislation allowing California Medicaid to pay for teledentistry services. And last, one of the more recent studies that we've done, we found a consortium of the University of Kentucky Medical School, a community center called North Fork Valley Community Health Center, and Ronald McDonald Charities, all working together to create both a mobile program and fixed clinic in Hazard, Kentucky, where there was a tremendous need from the population for oral health services that has been extremely successful.
Thank you, Marcy. So in closing, I think one of the key questions is, who wants to know about this? Who are the stakeholders that we want to reach? And there's a wide array of them. The federal government, state planners and policymakers, health and oral health professionals, providers, their associations, consumer advocates, oral health coalitions, educators, patients. Probably one of the most interesting examples right now is, so we've just released our report on the FQHC case studies that we did around integrating oral health and primary care. And in the last month, HRSA released money for oral health expansions at FQHCs. So we're trying very hard to make sure that all of the FQHCs in the country are aware of this report and some of those key findings to help them plan what they do going forward. So I'll close for now. I just want to let you know that any of the reports that we've discussed that have been released, we provide links to. And again, as I said, some of the reports coming out of the Oral Health Workforce Research Center haven't yet been posted, but probably will be in the next 6-8 weeks. So that's it for our presentation. Here's our contact information, and so now we can open it to questions.
Here, Merle Cunningham here. Thanks a lot. This has been most stimulating and enormous amount of useful information. Let me start off the question. You've comments about looking at the content of the curriculum or other training programs. Could you just say a little more about any challenges you see in getting access to the folks that have curriculum control, nurse practitioner training, and medical school training, and curriculum requirements for residency programs in family medicine, pediatrics, and internal medicine, since they all are different and they don't often talk to each other?
You know, that's a real interesting question, Merle, and I will tell you that there is a group that is sort of a coalition of different health professions, including nursing, nurse practitioner, PA, and it's kind of led by the PA group, but there are and medicine as well, with an effort to kind of support the development of oral health assessment competencies. So what's happening is that there are opportunities for these different professions to learn from each other about what goes into the curriculum and how it plays out in practice. And as Margie mentioned, one of the things we're doing this year is actually surveying some of the PAs who have obviously completed training in these assessment skills to understand the extent to which they can actually use them in practice, and if they can't, why not? So, and our sense is that anything we learn about the PA experience would certainly apply to the others. Margie, did you want to talk about the...
You know, there are several indications that, in fact, there's much more awareness within the primary care environment of the importance of oral health. HRSA just funded an interprofessional health competency research to develop a curriculum for training of primary care physicians. There are also any number of collaboratives and also grants that are being provided to educational programs. There's a big one at Northeastern University that is in interprofessional education on many subjects, but one of which is oral health care. So the curriculum, the Smiles for Life curriculum that I referred to, that was developed by the Society of Teachers of Family Medicine Physicians, is increasingly used. When you look at the history of the program, you'll see that it's changed. I think it's in its third edition right now, but it's accessed by thousands and thousands of people every year as a resource for learning about how to perform an oral health assessment. So there's lots of indications in the environment that there's interest in integration.
And that the professions are talking to each other about it, which is even more heartening.
I don't really know whether dentistry is at the table for the Minneapolis Center, Minnesota, the interprofessional group. I don't recall the dentistry's at the table. I think it's all for people.
You know, I right, and again, I would point to the fact that I think that right now primary care gets a whole lot of attention, and because there's a great deal of concern about how to effectively build capacity, and I really worry a lot about the fact that there is much less focus on oral health when this could be a prime opportunity for finding ways to integrate. So, you know, from what I've seen from that center, I don't recall anything about oral health. I guess that doesn't mean there isn't, but there does seem to be a focus on the medical side of things.
Well, since it's a bureau that's funding all of these research centers, including Minneapolis, that's certainly not an inappropriate point for us to help bring to the attention of HRSA leadership, since I know Jim McCray is personally interested in seeing this move forward.
Yeah, no, excellent point.
Okay, we have another question from among the audience.
Hi, I'm Darla Bishop. I'm a doctoral student here at the Millikan Institute. The question is around the Smiles for Life curriculum. I work outside my academic environment, Medicaid MCO, and we are looking for opportunities to bridge that gap amongst our dental providers and our medical providers, because we know that is a major part of getting their dental care. Do you know if that for Life curriculum is available for that we could purchase or offer it with CEs through our provider network? Or do you know who to reach out to find that information?
You know, I'm going to tell you that public access can go on and take the course. Anyone can go and do it. You know, there's certification at the end for completion. You know, I don't know about how it can be scaled, but I am certain that the Society of Teachers of Family Medicine would be happy to talk with you about, you know, scaling it to your need, or, you know, what would be required to scale it to your need. So I'm just going to encourage you to go just do a search on Smiles for Life. And you will, the curriculum is it. I think there are 8 modules currently. And some PA programs actually just tell their students to go on and access, and then they bring in proof that they completed one part of the core curriculum, or 2 parts or whatever.
And you know, one of the things to think about is just asking the existing providers about their exposure to oral health assessment, you know, coming into this, that they may be familiar with some of the things that are already happening so that, they may not need to take all of the Smiles for Life modules. But the other thing, I think, once everybody kind of agrees that it's a good idea and it's really important, is build the plan for making sure that the oral health providers and the medical providers communicate with each other and work collaboratively. Some of the things we found in the FQHCs were pretty amazing. So those who were most integrated, when there were well-child visits for kids between the ages of 1 and 3, they actually scheduled a dental hygienist to be part of the team that would conduct the oral health assessment for the child. And we actually interviewed one of the dental hygienists who did this, and one of the things she said was, the great part about this is that you're not having to undo things, that you're really starting with people who are, moms who are, concerned about their baby's well-being, and you can start creating opportunities for oral health literacy, as a good start for maintaining their child's health. So again, it's just a great opportunity to create some synergy between the two.
Thank you. So second question that I'll follow up by email. I'm Darla Bishop from George Washington, so you'll hear from me in the next 4 hours. Thank you.
We will be looking for it.
Well, my question is around another thing that we're very interested in at Medicaid MCO is emergency department diversion. And so I'm interested if you know of or heard about any models focused on oral health, because we know here in the district that thousands of kids are going to Children's Hospital because of oral health issues, and that presents an opportunity for us to do emergency department diversion through appropriate primary care and triage. And just wondering if you know of any models out there that we could look to as an example.
Of several, a variety of different models. One we encountered in Connecticut was the FQHC placed health access personnel at the emergency department to help patients who arrived for any health issue that was avoidable, any ambulatory care sensitive condition, but especially for oral health, so that when the ED identified that this was in fact a dental issue, the health access person would help them effect an appointment the day or that day, if possible, at the affiliated FQHC.
So the FQHC actually held appointments for the people who were showing up in the ER that needed emergency dental services, and it kind of strengthened ties between the hospital and the FQHC.
And let me say that just characteristic of Connecticut. We heard it in Rhode Island and in several other places that the FQHC dental clinics allowed walk-ins, especially for those referred by hospital EDs. I've also remember in Maine some years ago talking with someone about a community dental diversion program where a dentist in the community had expressed a willingness to accept referrals from the ED, so that when a patient arrived at the ED, they were given a list of dentists in the community who could actually address their dental condition. So there's a number of, local initiatives, again, based on what the resources in the community are. Not everyone's going to have an FQHC right next door. They may have to rely on community dentists. And in rural areas, frankly, critical access hospitals and community dentists really do act in partnership quite often, simply because they are the providers of last resort for many people, and there is sort of an obligation to serve the community. So we find that that they're willing, that many dentists are willing to accept one or referrals from the EDs.
Merle again. I was a chief medical officer at Brooklyn with the Lutheran Health Center system for 20 years, and one variation of the model is that we actually had our faculty and our residents being on call for the emergency department for selected areas. Since we had to staff up with all of the specialties that were piece of a faculty and they had practices in the area, we were able to actually use our own people to be in the emergency department to provide the emergency service there and do that referral. Of course, that's only applicable for health centers that have a training program and have the faculty to do that, but that's just another variation of a way that could work together.
In fact, I think Lutheran now has one dental laboratory that's reserved only for emergency services. So every dental laboratory at Lutheran is not scheduled for regular appointments. It's left open for emergency patients.
Yeah, we've done that, remember, for quite a while. We have 15 chairs at the main site where the health center happens to be in the same building as the community hospital, which is somewhat unique in the country for FQHCs. But it's
Merle, another that's happening, and this may be unique to New York, but as you know, licensure for dentists in New York requires completion of a residency. I know of some instances where, hospitals have helped develop the residency and actually use the residents to do the ER triage as part of their learning responsibilities.
Yeah, that works actively when the sponsor of the residency program is not a school. When the sponsor of the residency training program is the hospital, like we have at Lutheran, then that's doable. When the sponsor of the training program is a dental school, it's a different entity and a different enterprise, and it's much more complicated to do that when it's a dental school.
Yeah, and it's unfortunate because, again, I think collaborations between education and providers could go a long way to build these strategies to expand access.
Yeah. I have one last question before we wrap up. You mentioned schools a little bit, but if it's not on the radar screen, I would suggest it becomes more prominent on the radar screen to better understand the relationship of health centers offering dental services within public school systems. Of course, at Lutheran, we were in 26 schools doing dental services, and many of those also had medical services, but I've been impressed in my travels. I do HRSA site visits around the country, and I've been impressed in many rural areas with a growing effort to have the health center offer limited dental screening in rural schools. And I was in one place in Wisconsin recently where they were in 7 counties in 40 different schools. It's not full-time, but on some kind of a basis, to offer the screening in the schools. And for health centers that aren't into this, they don't necessarily appreciate that every child is covered by dental insurance, almost every between Medicaid and CHIP in the whole country. So it's a strong revenue stream. You even offer the free screenings there and bring the kids to our service. And, it's a center if it's done properly. So if that isn't on the radar screen in the past, in a rigorous way, that's a suggestion for the work of the coming year.
It's a very practice in many states, particularly in states that have expanded scope of practice for dental hygienists. Schools to be school-linked oral health programs, mobile dental programs, and school-based health clinics are more and more integrating a whole range of dental services. Some are simply screening and assessment, others are fluoride varnish and sealants, still others include full preventive services, including prophylaxis, and others are able to provide even dental treatment services to children, which is very helpful because it treats them in place. Parents are often impeded by not being able to take time for work or not being able to provide find a dental provider can provide a convenient appointment. So providing early service schools is a strategy that many states are encouraging.
Yeah, great, yes. Okay, well, thank you very much for your time. We certainly appreciate this, and we look forward to follow-up as appropriate in the coming year. and
Great.
look forward to working with you any way we can help with the dissemination of all of this great information. So
Thanks, Merle.
again. We appreciate
Take care.
it. Okay.
Bye.
Bye.